All right, we're going to go ahead and get started. My name is Shawn Maurer with the Smart Energy Design Assistance Center. I'm one of our senior energy engineers. Today we'll be discussing COVID-19 building safety for K through 12 schools, looking specifically at implementing measures and communicating those measures to your community. The presentation today is brought to you in partnership with the Illinois Extension Office. The Extension Office links the local communities to the university to develop programs, tools, and knowledge to support health, community, food, environment, and economy. The Smart Energy Design Assistance Center has the main primary goal of reducing the energy footprint of Illinois, and our primary concern with the COVID pandemic is making sure that as you're upgrading your buildings, making them safer, that you're also addressing energy and minimizing how much impact updates to your facilities may have. Joining me today are Dr. Newell and Dr. Helen Nguyen. I'll let them introduce themselves. Ty, do you want to start us off?
Good morning. It's a pleasure to be with you, and I look forward to our presentation and interaction. Thank you.
Hi, I'm Helen Nguyen, and I am a professor of Civil Environment Engineering. I'm also looking forward to interacting with you and sharing some of the work we have been doing related to COVID-19.
Thank you very much. So today's learning objectives: first, gathering data. This is going to help you identify what risk level your facility has and whether the mitigation measures you're having in place are effective, and also verifying ventilation levels, as that's one of the key components to mitigating COVID transmission risk in your facilities, is increasing fresh air rates and increasing clean air delivery rates. We're also going to look at how to implement solutions, learning about helpful resources to develop and implement an implementation plan, and then how to communicate to your community, to your staff, to students that you are making your buildings safer and reducing their risk in coming back to the facility as much as possible. We are conducting a study to help assess the outcomes of our COVID training webinars. We want you to know how the information we will share impacts your understanding and application of building safety practices during the COVID-19 pandemic. Participating in this study will include answering a few poll questions during the webinar and completing an anonymous 5-minute online questionnaire at the end of the webinar. You will be contacted in a few months to complete a second questionnaire. It's a voluntary study, and all questionnaires will be anonymous. We've prepared an information sheet that lets you know more about the study, and that link will be provided in the chat. The first thing I want to do is just touch base a little bit on our last presentation and the topics we covered there. We did cover that masking and social distancing have a large impact on infection risk. Social distancing and forming student cohorts, groups that stick together throughout the day, make contact tracing easier and limit any potential outbreaks in potential size. Hand hygiene and surface sanitation limit contact transmission risk, and increasing the amount of fresh air through building ventilation strategies and increasing your filtration rate help ensure clean air delivery. If you're in an area that has higher risk, then you may want to look at additional measures such as in-room air purifiers. And we also discussed a little bit about tracking fresh air delivery through CO2 sensors, targeting a level of 800 parts per million either through monitoring of your BAS system or through handheld CO2 sensors. And we'll get into a little bit more detail today about how to do that. But I did want to launch a poll for those of you that attended our last webinar, just to check on how much you retained of that information, and for any new attendees, what you already know about those. So our question is, from our last webinar, which measures must be implemented for the other measures to be effective to improve safety during the COVID-19 pandemic? So there are multiple correct answers to choose here. Face masking, social distancing, sanitation and hand washing, increasing ventilation, increasing filtration, and adding air purifiers. So if you would enter your selections there. I'll give it just a couple minutes for people to get their answers in. Again, if you did not attend our last webinar, just put in your best guess and we'll briefly summarize here in a second. Okay, looks like we've got most of our responses in, so we're going to go ahead and share those results. So the first three, face masking, social distancing, and hand washing and sanitation are key components of risk mitigation. Those are going to get you 80 to 90% of your risk reduction. Increasing ventilation, filtration rates, and air purifiers, if you don't have the other three in place, are going to have a minimal impact on your risk. And actually, Ty will be getting into that a little bit later with a calculator that he has developed. We do want you to know that these ventilation measures are important, but they are not going to have as big an impact if you do not have those core face masking, social distancing, and personal hygiene and sanitation in place, because those are going to give you most of your source control of the infection risk. If you did miss our first webinar, it is available at our website. You can look for it there. We have recorded the full webinar so you can watch it on a YouTube link. So the first thing you want to get into is resources, gathering data. Most schools are keeping track of the basics, how many people they have in a building, have positive test results, who they've been in contact with, doing contact tracing, how many people have been isolated or quarantined as a result of testing or symptom diagnosis, how many people have recovered and returned back to the building, and where community levels of infection are at. And so we do know that most schools are kind of tracking these core basics. Before we get too far into the presentation, I did forget we had one more poll to launch. And this is our preliminary knowledge base poll for everybody. It's going to be asking questions about the content we're covering today. So our first question is, for our CO2 readings in the building, what's an optimal location for taking a CO2 reading? Put your best guess in that answer there, either at desk level away from occupants, next to a supply diffuser, next to an open window, or in the center of the room. What is the minimum target air change rate for fresh outdoor air? 3, 4, 6, or 10 air changes per hour? And the last question, which is a good metric for communicating building safety measures to staff, students, and communities? This is a multiple answer question, but a school dashboard indicating infected and quarantine counts, a weekly newsletter reporting mitigation efforts, links to air quality reports, reporting estimated risk of transmission, or all of the above. While people are answering those, I just want to get a little bit more into data gathering. So we do know most schools are gathering kind of this basic information. What we wanted to get into was how to get more in-depth in that information gathering, and how to target it towards identifying those individuals that may be ill, and making sure that those specific people are quarantined so that the school doesn't have to shut down if you get a few cases. You can limit quarantining to just those students who are impacted. It looks like we've got most of our answers in for our poll, so we'll go ahead and share those results. Looks like most people think desk level away from occupants or the center of the room, and we'll touch on that a bit later, but one of those is the correct answer. As far as the minimum target air change rate, looks like we've got an even split there, so that's one we'll touch on in depth and make sure people know the answer to that question. And then a good metric for communication, looks like most people got this one. It's all the above. Any way you can get the word out to your community. Different schools are going to have different methods based on available technologies and funding. So all of these are good ways to share what your school is doing to be more safe for the community to attend. So one of the ways you can communicate or gather data on risk for your school is testing. Testing at schools can be coordinated through the University of Illinois Shield Saliva Testing Program. That testing costs about $10 to $35 per person. You can target individuals with symptoms or at higher risk. Some schools are just testing everybody. I know the University of Illinois is testing everyone on a bi-weekly basis. Overall test numbers can be used to report school safety and relative risk. If you're finding that your school typically isn't finding anyone with a positive COVID test result, or those numbers are fairly low, you know that your school's mitigation measures are effective and you can communicate that back to your community. This testing can help reassure staff and community that that illness can be identified and stop those outbreaks before they happen. These test results can be turned around within a few hours to less, usually within the same day. And so it's relatively quick. You can find out who has tested positive for COVID in the same day, make sure they get isolated and quarantined, and prevent them from infecting more people in the facility. Another thing that you can get into that may be a little bit more economical for schools is wastewater surveillance testing. And Dr. Helen Nguyen will be getting into detail about this program in a minute. But primarily you're going to be looking at sewage sampling rates and finding COVID in the sewage coming out of the building through testing the main sewer line tap coming out of the building. And it gives you an idea of the how many people may have COVID and whether you want to, if you see increasing numbers, you may want to be increasing your mitigation levels or going back to a hybrid or remote classroom setup. And so I will let Dr. Nguyen touch on the wastewater epidemiology program.
Very good. Thank you for very good introduction. So today I would like to share with you some work that has been done actually very actively globally everywhere. Wastewater epidemiology. So this is not a new field. Environmental engineers have been using that for decades. However, recently, because of the COVID-19 pandemics, that become very popular. So this map here is maintained by UC Merced, and you see that this is a global network of wastewater monitoring for SARS coronavirus 2. Next slide, please. And this is only one example of data showing that the sewage SARS coronavirus 2 concentration agrees with clinical data. It has been found in multiple places, and it shows that we can really use the sewage for this purpose. Next slide. The reason is that we can see that collecting wastewater is a lot simpler than collecting samples for human. Okay, and because you don't, it's like you're collecting a pool sample from a population, a community. A lot of time, engineers collect a sample at wastewater treatment plant. And in many cases, they show that the wastewater surveillance can use at the early warning systems because when people shed the virus, some of them may not actually show clinical symptoms. So looking at the virus shed in wastewater is a very useful tool. Next slide. And so SARS coronavirus RNAs have been found in asymptomatic children in different type of samples. So in this data here, you saw that the y-axis is the viral load RNA, and the x-axis is day after onset of the asymptomatic and symptomatic. Okay, and you see here the SARS coronavirus RNA is actually very heavy in feces compared to saliva sample and nasal swab samples. So we have been doing sewer monitoring at neighborhood level in 3 cities in the public health districts. So this data here show the sample site that we selected in Rantoul. One side, the first side is the wastewater coming out from the pork processing plant. So it's mostly produced water, not human waste. And site 2 is a sampling site near a trailer park. And site 3 is near a very well-established neighborhood in Rantoul. Next slide, please. And here all the data, here the map showing the sampling site for Urbana-Champaign. Site 4 is Campus Town. Site 5 is in East Urbana near Ty's house and my house, not very far from us. Site 6 is on West Champaign and site 7 is Northwest Champaign. So those sites were selected in discussions with the public health districts, Urbana-Champaign public health districts. So we look at many informations, the infection rate and also demographic level to we try to find sites with different characteristics. Next slide, please. And here are the data. So we started the work in January before the campus, the student, University of Illinois student came back to campus, and also before the local school opened. So I'm showing here the data between January and March of 2020 of this year. And so site 1, as you remember, that is a produce of water, so we didn't detect anything. In site 2, we detect 72 positive samples. Site 3, we detect 29% positive samples. So in total, in Rantoul, we detect in 33, so a third of our samples collected is positive. In Champaign-Urbana, the campus town, we actually detected as soon as student came back to campus, and we have been following it, and it's about 50% positive. In East Urbana, we also detect that very early, about 20% positive. Site 6 in West Champaign, we did not detect any SARS coronavirus or RNA for 2 months. Site 7 in Northwest Champaign, about 10% positive. Next slide, please. So this is how we collect the samples. So we identify the manhole when the sewer go into one place, and then we install a sampler, and we collect composite samples, meaning that we take a small volume of sewage every few hours, and then we at the beginning we take the sample twice a week, and now we take the sample once a week. And this is my group that's doing this work, and you can see that it's not simple, but it can be done. So sewage monitoring can be done in places where frequent human testing is not available. It's not replacing human testing, but it complements the human testing. Thank you. That's all I have.
Just a quick question for you, Dr. Nguyen. When you're doing that sample testing, are you looking at the concentration in that sewage and kind of tying that back to a potential level of community infection? Or are you just detecting positive versus negative sample tests?
So we we can do quantitative concentrations. However, we did not plan to get an accurate number is actually very complicated because it turned out that the virus signals, the RNA signal is not in the wastewater itself, but in the solid part of the wastewater. So sometimes we actually found them in toilet paper. So it's to get a concentration is not a trivial questions because you can imagine that they are very different case to case. In a lot of study that I show you before, people other researchers took the sample at the wastewater treatment plant itself, and therefore they can scale up and calculate the concentration. But in our case, we actually sample the wastewater very near, close to the community. So it's more complicated to get the concentration now.
Okay. Thank you very much. So the next thing on kind of data-driven tools, we've looked at testing. You could use the wastewater testing as kind of an initial indicator. Do you need to do more human testing? And that way you're kind of limiting your testing costs until you need to do more testing. And then actually identifying those people who are ill through actual personal testing. Next thing on data-driven tools is estimating the impact of your mitigation measures in your building. How much have you reduced the risk in your building through implementing face masking, social distancing, changing ventilation rates? And so how does that risk of infection for susceptible people decrease with the implemented measures that you've got in place? What was your baseline risk level? And Dr. Newell has developed a calculator that can help estimate that risk reduction level. He is interested in working with school building operators to understand how to make the calculator more user-friendly and to help schools document the effect of their mitigation measures and the impacts on transmission risk in their buildings. So Dr. Newell, I believe, will be willing to turn it over to you.
All right. Hopefully you can hear me okay. And thank you very much for the opportunity to discuss this COVID safe space calculator. And I hope you'll spread the word to others as well. And then either contact me directly or contact Shawn and the folks at CDAC. We work together on these issues. And if you'd like to set up a workshop targeted to your specific school or group, we're more than happy to do that. And overall, we want to help you understand more quantitatively how these measures will impact your school opening. So there's a number of other places that have calculators, and most of our computations are based on the same type of analysis using a contagion spread model that looks at airborne spread through building ventilation systems of contagion, and then how mitigating factors like diluting it with fresh air, filtering it, wearing masks, as well as the impacts of things like a vaccine, and putting a combination of these factors together, which are shown on the left-hand side of this calculator, result in outputs. And this is in a spreadsheet that you can download. It's free to use, and you can also change it as you see other things that you might like to add in. But the overall basis of this calculator is to put in the things from what should be a familiar basis to your facilities folks, as well as to many of you without being a specialist in building science, and in a manner that allows you to take action. And without going into the background, but when you go to the website where you can download this calculator, that there's explanatory notes in YouTube's on, for example, why carbon dioxide is such a critical parameter. 1,200 parts per million of carbon dioxide is essentially what standard ventilation provides you with. And we would recommend, and we'll see the results of that, going to 800 parts per million. What that means as far as fresh air is that you're going from about 20 cubic feet per minute per person of fresh air to 40. You're doubling it. And while those of you who are more directly involved in facilities may be throwing your hands up saying, we can't possibly double it, we're going to lose capacity, utility bills are going to go out of sight. When you look at the supporting information, as well as the additional worksheets in this calculator, that you'll find that the cost difference here in January in Illinois, if I had no energy recovery and I simply double ventilation from 20 cubic feet per minute to 40, which means that when I measure carbon dioxide indoors, I'm going from about 1,200 parts per million down to 800 parts per million. The cost difference is about 1.5 cents per hour per person of utility bill. And I guarantee you, you'll have difficulty seeing that difference in your facilities school utility bill. And so it's not a huge expense. For sure, you want to consider energy recovery, but it is not a huge expense. So when you put in these inputs, and there's explanatory notes in the worksheet, and you get over to this other side, and there are other calculators, as I mentioned, Harvard School of Public Health, MIT, University of Colorado. But really the thing that distinguishes this is that it's based from the perspective of operating a building and giving you parameters that people operating buildings are familiar with. And then the output is boiled down to, if I walk into that building and I'm a susceptible person, I don't have immunity, and an infectious person walks in, what's my chance if I'm in that building with 1,200 parts per million of carbon dioxide, about 8 hours of exposure, and number of people and vaccinated people along with filtration. For this standard case shown on this sheet of 11 people, one person's infected, I have a 72% chance of coming down with COVID. More importantly, and the objective as you work your way through a school would be, or a classroom or an auditorium or whatever situation, is to get this infection multiplier below 1. Infection multiplier of 1 is a ratio that says that infectious person is able to make one other person infected. And when that ratio is above 1, like 7 here, that's when the disease is accelerating. When it's below 1, an infectious person can no longer replicate that disease. Next slide, please. And as I just mentioned, there's these complex interactions among these factors, behaviors such as how willing people are to effectively wear face masks. And then there's the other things related to how the building's operated, the occupancy allowed, the exposure time, the ventilation levels, and the filtration. And that results in the two things we want to know. Is it a 50-50 proposition I'm going to get infected, or can I reduce that? And then the primary objective, getting the disease to die out, to decay. Next slide, please. And within the school environment, this tool is meant to be a communication tool to, instead of just throwing the problem over to facilities folks, to have facilities folks, administration, teachers, unions, PTAs, and others to be able to gather together and to have understandable results so that as you adjust these results, as you adjust how you're going to operate the building, as you look at policies on masking, that you can then see whether or not you've created an indoor environment in which in which COVID is going to decay, infection multiplier below 1, and that you've reduced the probability that susceptible people will get infected. Next slide, please. And so this is just kind of a progression of using the calculator, showing first on the immunity, if no one's immune, everyone's susceptible, and an infectious person walks into a space. So in this case, assuming, say, a room with 21 people, 20 students and a teacher, and under standard conditions, they're together, let's say 7 hours, and standard ventilation, nominally 20 cubic feet per minute per person, which would result in about 1,200 parts per million of carbon dioxide, with typical classroom activity, office level activity, metabolic rates going on. MERV 8 filters, which essentially are non-filters as far as removing contagion from the air. You need MERV 11 or better. And then no masking. So when we look at the results under standard conditions, it is like tossing a coin. And an important feature to note that the calculator shows that a number of people are under false impressions is that as we become more and more immune through vaccination, as well as disease-acquired immunity, that the so-called herd immunity, 75% to say 85% level of immune persons, this does not mean that unvaccinated people are protected. As you can see, if I'm susceptible and I'm in that room, whether everyone else is susceptible or everyone else is immune, if an infectious person walks in, my chance of getting the disease stays the same. Herd immunity does not protect me personally. It simply reduces the infection multiplier below 1, where the disease will decay out. Now we can see under standard conditions, as we vaccinate, as we become more immune, we are reducing the infection multiplier. The ability of an infectious person to spread the disease is decreasing significantly. But we can do better. We can double ventilation rate, and we effectively decrease the concentration of contagion, and we've significantly decreased my chance of getting sick in that environment. And that also decreases as we gain more immunity, the infection multiplier. If I recirculate a similar amount of air, about 40 CFM per person, through a MERV 13 filter, I have another significant decrease of the probability I'm going to get sick and decreasing the infection multiplier. And here you can see, without masks and with a high enough immunity, under these conditions, the disease should not propagate on average in buildings with this level of ventilation and filtration. Now let's look at masking. The loose-fitting cloth masks, which have been a lot of data on their effectiveness, if mask use as well as the type of mask, like a loose-fitting cloth mask, are used, you get a little improvement, but not what we need when we're implementing face masks properly. We can get masks, N95, which are primarily now available for medical personnel and other frontline workers. Perhaps your school has been able to get a hold of these, or the more widely available KN95, which also give you, say, a 90% contagion filtration capability. But if we significantly boost effective mask usage and mask efficiency, a person exhaling contagion now is only exhaling 20% of what's coming out of their breath into the room, and somebody inhaling it is only inhaling 20% of that 20%, significantly knocking down the concentration that gets into a susceptible person's lungs. Now, and the lower this infection multiplier goes, the faster the disease goes away. And if we had perfect face masks and totally fresh air ventilation outside, we would get rid of COVID within a matter of about 3 weeks. Next slide, please. One last example on this. We're hearing a lot about variants. They're increasing the transmission of COVID, and this multiplier called quanta per hour, the current COVID strain is considered to be spread at about 100 quanta per hour by an infectious person. And a quanta is a dosage of a virus. And 1 quanta inhaled into a person's lungs means that you have about a 65% chance of coming down with that disease. So doubling it from 100 to 200, as some variants seem to have better transmission efficiency, that this is effectively saying that 1 person is putting out a larger dosage. And if this variant also reduces the efficacy of the vaccine, say from 95% down to 60%, we can see the progression of the steps we just looked at. Here, going to 100% face mask usage, 90% effective face masks by, say, a teacher, but only 10% efficiency of use by everyone else. And so in this progression, this is looking at you, the perhaps teacher or other person concerned about getting infected, wearing a good mask and wearing it throughout the day, and others not so concerned about effective face mask wearing. And what you see in this is that if you wear an effective face mask, like medical workers have demonstrated to us, we can get this infection multiplier down, we add more fresh air and filtration, we get it down further, and then we have variants kick up. We can still maintain a safe environment. We have a cushion here to get rid of the variants as well. Next slide, please. And so I'll leave it at this, that we understand this disease as far as its progression and transmission in the air. We understand the impact. Professor Nguyen and her colleagues ran a wonderful experiment in one of our local bar jazz venues, and we demonstrated directly that fresh air and filtration gets rid of the ultrafine particles that are coming out with airborne contagion laden on them, droplets coming out of our lungs. And we can do this in every environment. And so this tool is hopefully something that can let you define within your various spaces a safe way to operate. Thank you.
We did have one question come in, Ty, when you were referring to the 20 CFM per person and 40 CFM per person. Was that in reference to outdoor air or recirculated air or total?
That's outdoor air. And so nominally the 20 CFM, but it's probably more typically about 15 to 20 based on ASHRAE 62.1 ventilation standards. And what we're recommending and what this calculator leads you to is going to 40 cubic feet per minute. And something else I wanted to mention, one of the other differences of this calculator and others is that there's 2 other worksheets, one that's an indoor air quality, sick days and human productivity worksheet. And it shows you basically what the results are on these steps to handle COVID effectively, how these impact building occupants' satisfaction or dissatisfaction with indoor air quality, and the impact of, say, increased fresh air and filtration on sick days, and it's significant. The progression I showed that gets rid of COVID, that helps eliminate COVID, also reduces seasonal flu and colds, the number of sick days associated with those, by 40%. And that 40% is equivalent to what today's flu vaccine does as far as reducing sick days. And then finally, it's been demonstrated that the impact of today's ventilation standards reduce cognition productivity. And in schools, for sure, we need everyone firing on all cylinders. But there's a good 10 to 15% drop in cognition productivity, about 9 different areas of cognition: creativity, decision-making, information processing, and that going to, say, 40 CFM per person improves productivity by that much. And then the other worksheet includes the impacts on energy so that you can discuss COVID in light of also air quality and productivity impacts, coupled with the impacts of ventilation. And then, as I mentioned, it's about 1.5 cents per person per hour without any energy recovery in a winter condition that you're talking about. And I think all of us are at least worth 1.5 cents an hour.
All right, thank you, Ty. Appreciate it. So the next thing we wanted to talk about was actually gathering that data. If you're going to use Ty's calculator or some other calculator, you're going to need to know your CO2 levels in the building or your air changes per hour. So the first thing we wanted to look at was CO2 levels. As people breathe, we emit CO2, so it's a good proxy for do you have enough ventilation in a space. If those CO2 levels are too high, it also means there's a good chance that you've got a higher risk in that space. And then air changes per hour, this is just the number of times the entire volume of air within a room or building is exchanged with fresh or cleaned air. Usually the air changes per hour is in reference to outdoor air, but it can also be in reference to purified air. So touching on the CO2 sensors, central automation system will often have these mounted in a return duct or as a wall sensor in the room, usually near the thermostat somewhere. If you don't have a central automation system that has CO2 monitoring, you can effectively monitor CO2 with a good quality handheld sensor. We've got a couple of examples shown on screen here. We do caution against some of the lower cost CO2 sensors as they do not maintain calibration and can give false readings. But initially, if you want to purchase a number of low cost CO2 sensors and have them in a room so that teachers can monitor their CO2 levels and try to kind of maintain that sense of security with air change rates in their space, letting them know that the space is below that 800 parts per million target. That can be a way to do that. We just would caution you that those sensors do have a tendency to drift in their readings. And so there is the potential to get a false high or false low reading. They should be checked against a quality meter. So where do you want to take these readings? What's the best place to do this? For central BAS systems, they're usually going to be mounted at about desk height on a wall away from the occupants, and that's where you want to take a handheld reading as well. It should be, whoever's holding that sensor should set it down and step back a couple feet so you're not breathing directly on that sensor and getting a false high reading. You don't want that reading to be near an outside air source. That's going to give you a false low reading for the space, directly under a fresh air vent into the room. Ideally, you would take the reading at an exhaust location to the room, but getting up to the ceiling where most return vents are would probably be difficult. So we recommend putting the sensor at desk height, stepping back a foot or two, give it a chance to set, because it will take a little bit of time for that reading to balance out with where it was in a previous space. Let it sit there for a minute and then take your reading, and that will give you an accurate overall reading of what the space's CO2 level is. We do also recommend when you first turn on these sensors to calibrate them, do so outdoors where you're going to get a good baseline reading of the outdoor CO2 level, and that helps ensure that the CO2 sensors readings stay better calibrated. You don't have any hysteresis in your readings that would cause them to drift higher. And as you're taking readings through the building, every few rooms or so, go ahead and take another outdoor reading. Make sure that sensor gets balanced back out again. But again, the keys for that reading in the space, you want it to be about desk level, away from the occupants in the space, so that you're not getting a false high or false low reading from another air source. Um, How many times would you want to take these readings? Initially, when you're first opening a building, if you haven't done this analysis already or had someone do air quality testing for your building, don't have a BAS system that's already monitoring this continuously. If you're doing handheld readings, you're probably going to want to initially do this a couple of times per day to ensure that when people are first coming in the building, when the building is at its max occupancy late in the afternoon, as CO2 levels are probably going to be at their maximum late in the day. You want to check multiple times through the day to make sure, as population sizes change in rooms, if you've got students moving around the building, that you're catching those different conditions and ensuring that under all situations your ventilation system is giving you adequate fresh outdoor air. Once you've got that baseline established and you've determined that your systems are working properly, then you can drop back to maybe 1 or 2 times per week, unless you run across a problem, and then you may want to ramp up testing in a certain area. But once you've got that baseline established, you don't need to be doing this continuously. You just want to do sample checks periodically to make sure that your systems are still operating correctly and that you're accounting for all situations in the building. The target bare minimum fresh air change rate is 4 air changes per hour, which is typically about 800 parts per million, which is typically around 25 students in a 1,000 square foot room. It's that typical ASHRAE design. You want to intersperse those readings again with an outdoor reading as you're taking them through the day, just to prevent hysteresis in your readings and make sure that sensor maintains calibration. And again, you can take these CO2 readings, put them in a chart, in a spreadsheet, some kind of database, and you can share these results with the community, with staff, with students to help show, look, we're constantly below this 800 part per million recommendation. That means we're getting adequate ventilation in our buildings, and we're maintaining safety for our occupants. If you don't have the funds to purchase a CO2 sensor, or don't have that set up in a BAS system, or are looking for another option, or something to do in addition to those CO2 readings, calculating the air changes per hour in a space. Again, this is just exchanging the entire volume of air in that space each hour with fresh and clean air. How are you going to be able to calculate that air change rate? We are seeing some recommendations for a total combined air change rate of outdoor air and filtered, purified air into a space of about 6 to 12 air changes per hour. That's equivalent to what some hospitals have in waiting rooms in different areas of the hospitals. It's a pretty straightforward calculation. If you know the height of the ceilings and the square footage of the room, you can calculate the volume of that room. Then all you need to know is the cubic feet per minute of fresh air coming into the space and the cubic feet per minute of recirculated, filtered, purified air. If that air isn't being filtered or purified appropriately, then you don't want to include that in this calculation, or you're going to get a false low air change rate, at least in regards to building safety as far as reducing viral content in the air. Take that CFM, multiply it by 60, divide it by the volume of the space, and that gives you your air change rate per hour. Where can you find those ventilation rates to rooms? A lot of the times that's going to be something you can contact the facilities people or a school architect. It's going to be in those plan drawings what the design air change rate for the space is. Another option is you can work with a contractor or purchase your own bolometer. It's a large hood that fits over the vents in the space. It can measure that airflow rate coming out of a HVAC vent or unit, and you can measure the airflow rate that way. But most likely, most people are going to have access to plans. Purchasing an airflow meter may not be possible. Working with a consultant is a good way to get those readings as well. If you have air purifiers in this space, they're going to have what's called a clean air delivery rate, abbreviated CADR, and that's reported in either CFM or cubic meters per hour. And so you can use that as well to calculate how many times is that, how many air changes is that air purifier contributing to your space. The reason we talk about 3 to 4 air changes per hour at a bare minimum is it's based on multiple studies. And this is one example by Bantelik and Tam that shows your infection risk, assuming well mixed air in the space. You've got kind of an even distribution of particulates, and various rates of quanta emissions. And what we're seeing here is that at higher emission rates, they start to level off at about that 3 to 4 air change per hour. When you start increasing beyond that, you're not getting much additional benefit as far as reducing infection risk for the additional energy that you're putting into the system. And so another thing to be aware of is once we get infection levels down, as Ty was talking about in his calculator, where that quanta of emission rate is lower through masking and social distancing and vaccinations, you can start to see once we get down to the quanta emission rate of 2 or less, then you're starting to see that increased ventilation has relatively little impact overall. But as Ty had noted, you're going to see other benefits from the increased ventilation of cognition, reducing the transmission rates of other diseases. And so that's why we're recommending that 4 air changes per hour is kind of that bare minimum target that most organizations are recommending for ventilation rates, as that's where you start to see that taper off in effective reductions. So assuming your space has ASHRAE standard ventilation rates, we're looking at a K through 12 classroom with 30 students and a teacher here. It's a 750 square foot classroom with an 8-foot ceiling, which is relatively low. Typically it's a 9-foot ceiling, but this gives us a nice round number for this calculation just as an example. But based on ASHRAE ventilation rates of about 10 CFM per person in a classroom, that's 310 CFM total for the students and the teacher. Your floor area is about 750 square feet, and so there is an ASHRAE ventilation standard for classrooms of about 0.12 CFM per square foot. If you combine these together, it averages out to about 20 CFM per person at design spacing for occupants. But in this instance, that's a total of 400 CFM for that space for the ASHRAE standard ventilation rate. How much outdoor air should you be bringing in? About 400 CFM. At that 8-foot ceiling height and 750 square foot, that's 6,000 cubic feet in the room. And so in this calculation, that equates to about 4 air changes per hour. We do know in some schools, classrooms are overcrowded. They were designed for, say, 20 students or 25 students, and you've got 30, 35 students in them. So that air change rate should be higher. Your effective air change rate at design conditions is going to be lower. So just something to be aware of. I'm going to kind of skip over these panel discussion questions. We'll touch on them at the end as we are a little low on time. But the next thing I wanted to discuss was developing a data-driven implementation plan. The plan should be responsive to data, infection levels, risk levels, community infection rates. The plan should address when the measures will be implemented, how and who's going to implement them, quality control, how to evaluate the effectiveness of those measures and their ongoing impact in the building. Should address costs and energy impacts. How are these measures going to impact the building's budget? Plan should address how compliance will be enforced and how efforts should be communicated. Infection data can help you decide whether your school needs to be more proactive, and this can come from testing, it can come from the CDC or the local health department's reported community infection rates, can come from individual testing at the building, but higher rates, you're going to want more measures implemented in your building. If you've got a particularly high infection rate, you may want to go beyond just ventilation and look at air purification systems. If you're in the lower regions, you may be happy with just, increasing your ventilation rates and making sure everyone's wearing masks and social distancing. Solution impact estimations can help you identify solutions that will have the greatest impact. Ty's calculator again was showing the various impacts of different measures implemented individually or all together as a package. And ventilation data can help you determine whether your current ventilation strategies are working or if you need to make more modifications. So one system that U of I has helped develop is the Shield K through 12 Playbook. This was developed in partnership with NCSA. But this is essentially a module-driven survey of what's your plan of action for your building, and it steps you through different sections of the plan. Cleaning of the building, maintaining social distancing, um, management of communication materials through IT, masking, testing strategies, and ventilation strategies. And this is just essentially a survey with some checklist options in it. Here we're showing an example of, what are you doing in a classroom to generate increased ventilation rates? And there's different options you can select, from opening windows all the way up to portable air cleaners. And depending on the options you select, it creates this activity checklist. And what this checklist does is it walks you through calculations for air change rates. It generates checklists for things that staff should be checking in the building. It tells you who should be doing those things. Should it be going to building operators? Should it be going to custodians? Should it be going to admin staff? Should those checklists be going to teachers? And so this just helps you develop that plan of action. Another important consideration for all these changes is how are you going to fund them? So there are a lot of federal funds available for COVID through the ESSER programs, the CARES Act, the Recovery Acts that have been passed recently have released billions of dollars for public schools to address these things, to set up disinfection, to set up testing for their facilities, to repair and upgrade ventilation systems. So how can these ESSER funds be used? 20% needs to be addressed towards learning loss and the impact of COVID on underrepresented student groups. The remaining 80% can be used for preparedness coordination with public health departments, setting up testing protocols, setting up isolation and quarantine protocols and contact tracing, sanitation training and supplies for staff, improving indoor air quality through repairs and upgrades to systems, planning and implementation of long-term closures, including continuing to provide school meals to students that need those, access to online learning and internet access so that students, including disadvantaged students who may not have access to internet at home, can still have access to learning materials, providing mental health services and support, hiring counselors, and addressing learning loss through summer school, supplemental learning programs, summer camps, and different avenues. It also can be used for hiring staff and maintaining staff and facilities. So how do you get access to those funds? The local education agencies apply to the state education department through their grant application portal. Those funds are allocated using Title I Subpart A allocation formulas. So there are fixed amounts that are available to different schools based on their Title I distributions. Again, applicants will register and pre-qualify through funding through that grant portal. A really good resource is available at ISBE on the step-by-step process to applying to those funds. The link is included here, and I believe we'll try to put that in the chat as well if you need access to those materials. Finally, we want to get into communicating data and mitigation measures. How is your school going to get the word out on whether your building is safe to return to, your mitigation measures, what your current community risk level is and risk for the school, and how you're making decisions at your facility? Why are you going to want to get these communication levels out? You want to reassure parents and staff that your buildings are safe to come back to and that you can reopen safely. You also want to increase transparency. Let people know what you're doing to mitigate risks in your buildings. And this can also help administrators make decisions about opening. Communicating rates of infection, quarantine, and active cases. Again, at a community level, this can help schools determine whether they want to go back to fully in-person classes, maintain a hybrid model, go back to remote learning in cases of high infection rates in the community. When you're tracking this among students, having a dashboard that's easily accessible at the front page of your school's website. This is where you're really going to get a lot of contact for people that have ready internet access, where you can have this information is readily available. Anyone can look at it. For communities that may have people that don't have internet access, a weekly newsletter that's mailed out to parents that has this as front page information. Um, this is what our school is doing to be safe. This is what our expected risk level is. This is our current testing rates for positive cases, showing a downward trend since we've implemented these measures. Or you want to tune that messaging to show that you're having an effect, a positive effect on bringing people back to the building and maintaining safety. How can mitigation, you want to communicate how your mitigation measures can reduce the probability of infection. As we talked about Ty's safe space calculator, you can communicate at risk level. You can show initial conditions in the building. This was our infection rate, our risk level. We've implemented these mitigation measures, and this is our new estimated risk level. It's much safer in our building now. The SHIELD toolkit also has a section on communication with helpful templates and ideas for how to get the word out to your community on how safe it is to return to your buildings. Communicating that visually is going to be a great way to get the word out there, because it's going to make it more accessible to everyone. If you can put a chart out that shows this was our risk, high risk with no mitigations and measures in place, we're requiring masks worn by everyone, we're increasing ventilation rates, we've increased filtration, this is how our risk level has dropped over time. This is a really effective way to show people the impact mitigation measures are having in your facilities. How do you communicate the effectiveness of ventilation efforts? Not everyone's going to understand air change rates or CO2 levels, but what you can do is explain, kind of graphically, in our rooms, we've got, this fixed volume of air. Our ventilation rates are changing that volume of air out every hour, multiple times every hour, so that room is a continuous supply of fresh, clean air. It's exhausting out any kind of infectious particles. You can help people to understand better how those ventilation rates are impacting the spaces. We do want to acknowledge that airborne transmission, it's never going to be a zero risk situation in your buildings. There's always going to be some level of risk, but you always want to communicate you're doing everything you can to mitigate that risk as much as possible. And you want to communicate to the community that you're doing what you can to achieve that good ventilation level. Two basic ways: increasing that fresh air ventilation through the HVAC system, and increasing clean air delivery for any recirculated air through filtration and purification systems. So when you're communicating to the community your mitigation measures, you're going to want to touch on those. This is how much clean air we're bringing into that space. Some examples of what other schools have done as far as communication measures. This is some examples from Chicago Public Schools. They sent out in a newsletter that they had done air quality testing in their facilities, and they had verified ventilation rates for their classrooms. Where they needed it, they had added air purifiers to those spaces to achieve that clean air delivery rate to the space. Some examples of messaging that you may want to use. You brought some experts into the building. They verified that CO2 levels are below this 800 part per million recommendation. We're measuring those CO2 levels on a regular basis to ensure that we're always meeting that target and ensure that we're keeping our teachers and students healthy. And we got a couple other examples of what that messaging might look like. Something else to communicate is long-term. As you implement these measures, what's the impact it's going to have long-term in your facility? Fewer sick days for students, increased productivity, better sleep and improved cognition, happier students. Healthier buildings, healthier air has a long-term beneficial impact long past this COVID pandemic. And so you want to communicate that as well, and make sure that these measures that we're implementing for increased ventilation aren't going to be a one-time thing. The pandemic passes and we go back to business as normal. We want to maintain these healthier facilities so that we're, one, prepared for the next pandemic, and two, maintaining these other benefits beyond the pandemic and energy. We're maintaining healthier buildings and healthier people. So to get into our wrap up, we had our poll questions coming up again, just to check that we covered our materials and see what you learned from our presentation. So we'll go ahead and launch that poll. So these are the same 3 questions we asked at the beginning, that we've covered through the presentation. What's that optimal location for taking a CO2 reading? Desk level away from occupants, next to a supply diffuser, next to a window or the center of the room. What's that bare minimum target air exchange rate for fresh outdoor air? 3, 4, 6, or 10 air changes per hour. And what is a good metric for communicating building safety? A school dashboard, a weekly newsletter, links to air quality reports, estimated risk of transmission from a calculator of some sort, or all of the above. And I did want to open it up to questions for the panelists, Ty and Helen. I'm not sure if we've had any questions come in at the moment. Helen, I did want to ask if a school wanted to get involved with that sewer sampling program, that wastewater sampling program, how would they get involved with that kind of testing?
Yes, so my lab is currently doing that and funded by College of Engineering. So I think the best way the school want to do it is through the public health department, and then they will route that request to the university, and then to me.
Okay, thank you. Okay, looks like everyone has answered our poll. So first question, optimal CO2 reading, desk level away from occupants. Looks like everyone got that one correct. Center of the room, for if you've got no other good space to take the reading, that may be a good place to do it. But again, you want to make sure it's away from occupants. You don't want to get a false high reading from someone breathing on the sensor. And you don't want it near a supply vent or something that's bringing in fresh air that's going to give you a false low reading. For the minimum target exchange rate, 4 air changes per hour of fresh outside air is that bare minimum target. That's what we're trying to hit with that 800 parts per million target as well. So that is the correct answer there. And then all the above, yes. Any method to get the word out is going to be effective at reassuring people that your facilities are safe to return to. We'll share those results. I reviewed them without sharing, sorry. So it looks like everyone got those correct. Very good, very good. So just to wrap up what we've covered, the recommended process for reopening facilities is gather that facility data, make sure that you've got air change rates, what your mitigation measures are, CO2 level readings for your space, information on your community's risk level for transmission, testing rates at your school if you're doing testing. Assemble that data and use it to implement a plan of action, and then make that plan of action, implement it, obtain that funding through the ESSER grants, and get your buildings to be safer. And then communicate out to the community what you've done, how safe your buildings are to return to, and everything that you're doing to help ensure the health and safety of the students and the staff in your buildings. What solutions should you focus on? Masks give you the biggest bang for your buck, and social distancing. It's giving you that source control of the virus. It limits how much concentration you have in the space. Once you get past that and you've got universal masking in your buildings, then you want to focus on ventilation and filtration to take care of those cases where you're mitigating the risk in situations where maybe masks can't be maintained or social distancing can't be maintained, such as during lunch periods when people are eating and have to take those masks off. Ventilation and filtration improvements are fundable. There are those ESSER grants. CDC also has grants for setting up testing with public health departments. You want to make sure that you're measuring those ventilation and filtration rates. and reporting that back to the community. You want to have some kind of communicable result that lets people know what you're doing to mitigate risk for your facilities. And then also communicate those long-term benefits. Beyond just making the building safe, you're also making it healthier, you're making students more productive, you're reducing their overall risk of sick days from other diseases. Um, We've pulled together a list of resources. CDEC has a number of COVID-19 resources for different facilities, as well as K through 12 schools. The COVID-19 toolkit for the SHIELD program, again, that questionnaire is a really great way to develop a tailored checklist for the policies you're putting in place at your specific facility. And then there are the generalized recommendations from the CDC, the Public Health Department, and the State Board of Education that give you a general outline of things for your buildings to mitigate risk and address the COVID-19 pandemic. We do have a quick 5-minute survey that we would ask you to complete. Again, we're going to open it up to some discussion here at the end, and we're looking for any questions that you may have on the different programs. If you're interested in Ty's calculator, please do reach out to either us or Ty, and we will coordinate with you to come out, work through that calculator, and help you determine what your risk level is. Okay. Let's see, we did have a couple of questions. See if I can find.
Hi, Shawn. It looks like we don't have any questions in the chat, but I have a question for Ty, actually. What are some key things that schools should be thinking about when developing or updating their building safety plan? I know you spoke a lot about kind of the planning and using the tool to help evaluate, but what are some of the key takeaways that our audience should know today about when they're looking to update that building safety plan?
Yeah, and that's a great question because as most of you are already aware and hopefully preparing for, there's going to be a lot of money to improve schools throughout the nation, and having shovel-ready projects defined is important. So there's no time to waste. But in any case, I think this tool is a first estimate with all the stakeholders involved to make decisions on, okay, how much ventilation is going to make this safer, and then how's it going to impact other factors like air quality, dissatisfaction, asthma attacks, sick days, things of that nature, coupled with an estimate of the cost of energy to achieve these better levels of indoor air quality, and the value of recovering energy. So a school that wants to, say, double their fresh air, but also to do that in a more energy efficient manner, to be able to look at the cost of energy recovery, ERVs, HRVs, DOAS, or other systems, and to get an estimate of an initial cost. Of course, these systems need to be engineered, but it starts to give you an idea of the dollar scale you're talking about to make these changes to your facility, but in a manner that all stakeholders can be involved in those discussions.
That's great, because I know that there are a lot of schools that are investigating how to use that money, where to best invest. And so that's a great framework to think about when you're approaching those sorts of updates to facilities.
Yeah, and you can do a lot, initially. So for example, a fresh air ventilation system. We have a local campus worship center that's putting one of these things in basically for their Sunday services, but you're talking maybe $10 to $20 per cubic foot per minute of airflow capability for the installation of one of these fresh air systems. So if you have, say, 30 students in a classroom and you want 40 cubic feet per minute of fresh air, you've got 1,200 cubic feet or 12,000 cubic feet per minute. As you go to that level, 1,200 cubic feet per minute, you're talking about maybe a $12,000 project for that particular space.
Gotcha. Okay, that's good information. And Ty, how have you been seeing other schools kind of communicating these things? I know we touched on some different examples, but what are you've been working with some school districts too. What are the common things that their pressures and barriers they're facing, and what are some ways that they're overcoming those, either with teachers or with their community, or sharing that with parents?
Well, I'd like to learn more on that, and so I'm hoping that our audience members, and in spreading the word, put more people in contact with us so we can learn more directly. But I'll tell you a couple of places that have, I think, some really nice presentations. The state of Michigan, and I can't recall the website, but I can look it up and send it to you. They have a really excellent presentation by a range of people, from Department of Education people, but engineers who are involved in these type of facility improvements, speaking on different aspects. And I found that webinar series very informative. And then also in Washington, D.C., there's an excellent presentation on what they have done. They seem to be well ahead of a number of other locations in implementing improved air quality and ventilation, and they discuss costs and some of the different things they've done to implement that. So there's some good sources out there. I think the difficulty I hear directly, and this is from like consulting engineers as well as others, is the quantitative aspect. So as you look at CDC and WHO and ASHRAE guidelines, they still remain quite fuzzy, even though as they've been moving the goalposts to include airborne, to say downplay more touching surfaces, but they've still kept it quite fuzzy. So you're not going to hear like 40 cubic feet per minute per person. You're going to still keep getting referred to follow the standards, but then try to improve beyond those. And
I see.
Mm-hmm.
So that's really great that we're able to kind of hone in these sorts of events to really provide direction to a lot of schools and folks to, on the different levels that are really going to work and be effective for their facilities too.
Yeah. And let me add, technology is going to keep marching along as we listen to Professor Nguyen. I mean, this is just fantastic that we're going to have this preemptive, unintrusive manner to just survey our communities, perhaps the waste coming off every aircraft, to just see when particular contagion comes into our communities and where. But also, I had a meeting with a fellow from our ECE, Electrical and Computer Engineering Department, where wearable CO2 and VOC monitors, they're going to be here now any day. So wherever you walk, you'll be, just like the biometrics on a smartwatch or phone, are recording information that helps us feel better and helps us be healthier. That will also be able to survey the air quality around us, as well as our exposure to various chemicals, particulates, and contagions. And
wow. I didn't know that technology was so market ready. That's really neat.
So yeah, I mean, and it's yeah. So the sensor that that was demonstrated to me, it's got a good 8 hours of capability, very lightweight. It's like the size, the current prototype size of like a conference name tag.
Huh. That's wonderful. That'll make it so much easier to be informed, to know when we're not in spaces that are safe. That's wonderful.
Yeah, and if you've eaten too much chili, it'll let you know that too.
That's funny. And so, one of the biggest takeaways I think from today's session, we've talked about communication, we've talked about tools to gather data, but really, what, in your opinion, what is the biggest piece of advice for schools that are looking to start collecting this data? Where should they begin, and how can they, use that data in the data process? I just want to reiterate that for our audience.
Yeah, I think the CO2 collection is, getting a CO2 sensor, $250 for a good plus minus 30 parts per million resolution sensor, and then just walk around with that in the school and just see how different spaces. You only need one space that's not properly ventilated and overoccupied and too much exposure time to keep spreading this disease. And so we need to survey every space as Shawn was describing, and then to take notes on which ones are, say, most urgent to address. And then those actions, whether an occupancy or reducing exposure time, or the ability to get a room filtration sanitation unit in place, as well as then seeing what you can do to bring fresh air into that room. And often fresh air is just on the other side of that window.
Exactly. And most of those CO2 meters have instructions and YouTube videos, right? So it's pretty easy to learn how to use those properly and read them properly, correct?
You bet.
Okay, great.
And more than happy to go around Illinois and visit any of you to work with you on that.
Awesome. And Ty is such a wonderful resource for our communities and for Illinois. So thank you, Ty. I'm going to turn it back over to Shawn.
As Ty mentioned, just walking through a facility and determining where you've got air quality issues, either with a CO2 sensor, or you can even do it looking through plan drawings and seeing if sometimes you've got an interior room that doesn't have immediate access to outdoor air through a window or something, so it's going to have to be some kind of ventilation solution. Identifying those areas where you've got higher risk because you can't implement certain mitigation measures, and planning for, maybe this room's going to need an air purifier to get that clean air delivery rate. But that's where the plan needs to start is, walk through your facility, do a risk analysis. We can help with that kind of analysis as well. Looking for those target areas where you're going to have higher occupancy and higher densities that are going to increase risk, where you can't bring in outdoor air for some reason. That's going to be a higher risk area, and addressing those. Where you've got malfunctioning equipment, maybe you don't have the funding to fix that equipment. Maybe there's a lower cost alternative, such as a small room air purifier or something like that, until you can get those funds pulled together, get applied for the ESSER grants to get that funding in. But that's really where it needs to start. All right. Seeing no questions have come in from the audience, I want to thank everyone for joining us today. Again, please do help us fill out that survey. That'll go a long way towards helping us assess our training programs. If you do need additional assistance, please feel free to reach out to us at cdac-info@illinois.edu, and we'll be glad to help you. Again, thank you all for joining us today. We hope you have a wonderful rest of your day.